Ladies and gentlemen, welcome back to my channel. Whether you are a student or you are a healthcare professional or you are a patient yourself and you're interested to learn something new, don't go away. So one of the questions that I have been asked lately, what is Kennedy ulcers? Kennedy ulcers are particularly relevant in palliative care. So let's dive into what they are, how to recognize them, and how to treat them. So Kennedy ulcers are also known as Kennedy Terminal Ulcers, and they are a specific type of pressure ulcers that typically develop in patients who are nearing the end of their lives. So they were first identified by nurse Karen Lou Kennedy in the 1980s. So these ulcers usually appear rapidly, so often within, I'd say, hours to days, and are considered a sign of a body's imminent decline. So if you're working in the patient and all of a sudden there's a sudden change in the status or the condition of the wound, and one of the things that you would be thinking about would be a Kennedy ulcers. So you always look for a red flag, because if you see this, it's one of the good talking points to the interdisciplinary team that you're now dealing with an end-of-life situation. So what are the characteristics of a Kennedy ulcer? So what are you looking for? So the first thing that you need to know is the location. Where are they located? So they're most commonly found on the sacrum, okay, with the lower back, near the tailbone, or on the coccyx area. So appearance is that, like what I said earlier, usually they appear, or the onset is usually rapid, so they can develop very quickly. So as far as the shape, they are often irregular, and they resemble a pear, a butterfly, or a horseshoe. So as far as color, they can be red, yellow, or black with a mottled appearance. But usually, in my years of experience taking care of patients with a wound, it's usually a black discoloration of the skin. So progression is that they can worsen very quickly, unlike other pressure ulcers that develop more gradually. So what are the causes and risk factors? Okay, number one is reduced blood flow. As patients near the end of life, systemic decline leads to decreased blood circulation, particularly to the skin and peripheral tissues. So the question is, if this is indeed a systemic failure resulting to circulatory problem, why is it that it preferentially affecting the sacrum and other pressure vulnerable areas? Why not the face, the hands, or the abdomen? In your clinical examination, it is imperative, or it is important, that you know what is normal, so that you'll be able to identify what is abnormal. So always remember two terms here: is a rapid onset and also what we call a terminal situation. And also the risk factors for this is immobilities. Terminally ill patients often experience prolonged immobility, leading to increased pressure on certain areas like the sacrum. If your patient has comorbid conditions such as diabetes, vascular diseases, or malnutrition, this could impair the integrity and the body's ability to heal, increasing susceptibility. So location, which is usually at the sacral area or on the coccyx area. So how about, okay, if you are a nurse, or yes, and you're asked to go out and see a patient, or have a referral to see a patient at home who is bedridden, and the reason why the patient is referred to you is for assessment or management of a pressure ulcer. And then when you are doing your assessment and you see this mottled appearance, it's dark purple or even yellowish sometimes, and you see this classic butterfly or pear shape or horseshoe shape is located at the sacrum, and you look at the overall picture of the patient, it looks looks like the patient is so malnutrition or malnourished, I should say, this should be a red flag for rapid referral to a medical team so that you'll be able to know what you're dealing with. Who knows, you are now dealing with an end of life situation and the patient is not, or the patient or family are not ready. Another situation, if you are a physical therapist and you work in an acute care setting and you are asked to get the patient out of bed, and of course that your goal is always to get the patient out of bed, but you see this red flag, are you going to get the patient out of bed in a patient with the Kennedy ulcers? My answer would be no, because getting the patient out of bed will just increase their discomfort. And always remember that your goal is palliative care in this type of situation. So do not get the patient out of bed when the patient is already determined to have a Kennedy ulcer. So I work in a wound care clinic as a wound care specialist, and a year ago I had this referral to debride a necrotic tissue of a patient with a pressure ulcer. She is a lady who lives in an assisted living facility brought in by two caregivers. And the first thing that I noticed, classic butterfly appearance of a black necrotic tissue located in the sacrum. So looking at the patient, the overall picture of the patient, she appears very malnourished to me. Luckily, I was able to access her medical profile, and the laboratory results that was taken lately indicates that the patient has very, very low albumin. There's no available pre-albumin at the time. That's the thing that I was also looking for, but it wasn't available. But the albumin level very, very low, which indicative of poor nutritional status of the patient. So what I did is I called the patient's daughter who lives in the Bay Area, and I told the daughter and explained to her why I am not going to clean, or I'm not going to debride the wound, because it may just add pain and discomfort for the patient. I requested the daughter to come to the Sacramento area to just bond with the patient, and I also made a very big case to the medical team, and true enough, it's not even patient passed. So that one incidence of or one example of the importance of knowing what you see. Okay, always remember, ladies and gentlemen, so that you know the normal, you should be able to, let me say that again. So that you know the abnormal, you should be able to identify what is normal. Okay, so if you're a nurse or a physical therapist and you're in charge in admitting a patient to your service, if example you work in a skilled nursing facility, or you're doing an oasis, if you work in home health, I encourage you to be very, very careful and very, very, very smart. And here is why. If you don't want to take the responsibility of causing a facility acquired bad ulceration, while in fact the lesion is already there during admission, or you don't want to be accused of making or allowing a pressure ulcer or pressure injury to get worse in few days while they are in your service. Be careful also not to mislabel or misdiagnose, and just to skip litigation. Let me tell you a story. This is a real story. I used to work for home health in the past, like years ago, and I was asked to assess a patient who has been on their service for so many years. I was a new employee of that private home health agency in the past, and when I was looking at the chart, they were talking about a Kennedy ulcer on this 82-year-old lady. She has been in bed, and I was the first thing that I look is like, how long has this patient been in service? And it looks like the patient has been seen by this particular home health agency for almost 2 years, and they keep doing a recertification and recertification. So what I did, the first thing that I did is I doubted if it's this really a Kennedy ulcer, because number one, the albumin level it's low, but it's not critically low, and it looks like the patient is not gonna die soon. So what I did is implemented a thorough assessment. And do you know, ladies and gentlemen, that the most effective treatment for a pressure ulcer is to remove the cause, which is pressure. So I am talking about proper positioning. Okay, that's the best treatment that you can offer to someone who has pressure injury in that area. And there are two things that happen. Number one, the ulcer got better, and number two, the patient did not die. So what does that tell you? What does it tell me? Probabilities are, number one, they misdiagnosed this. I've learned from a seminar or from an article that if you see that, this is how a Kennedy ulcer would look like. Okay, so it's mislabeling. You're just excited to put the label, and you're happy to make a diagnosis. Or number two, I'm not saying that they did it on purpose, but people could mislabel or misdiagnose this intentionally just to skip litigation. As we continue with our discussion, interesting questions would be, are Kennedy ulcers considered pressure ulcer? There is still a debate whether or not Kennedy ulcers are considered pressure ulcers. Most clinicians think that it's just part of the dying process. Some clinicians believe that it has a pressure component on it, that therefore they need to be staged. Well, in fact, if you work in a skilled nursing facility, MDS requires that if there is this intact KTU, that should be labeled as stage one, and with the formation of the eschar, that should be labeled at stage 4. And it just makes sense in the clinical scenario, because most of the KTUs that I've seen in my bare eye are actually located in the sacrum. However, literature could support that you can also see this in other weight-bearing areas in the body, like, say, for example, the elbows, on the heels, and other places of pressure sensitive areas. Patient who has a sudden change in skin condition, say for example you have like a stage 1 looking skin breakdown or skin condition in the sacrum, and all of a sudden it transforms into a full thickness wound, do not accept the blame, because this is otherwise unavoidable life. In fact, according to the American Medical Directors Association, in 2008, they stated in their guidelines that KTUs are otherwise unavoidable. Always remember that the skin is the largest organ in the body, and so like other organs, the skin can fail. In fact, 25 to 30% of our cardiac output is distributed to the skin. So don't be surprised if you're a nurse or a therapist working in the intensive care and the patient is on vasopressor. Remember that the aim of vasopressors is to divert the circulation or blood flow to the major organs of the body so that the patient will live. That means to say that it's going to compromise the perfusion or the circulation to the skin, so the skin could fail. So patients who are in vasopressors are very vulnerable to skin breakdown. So extra care must be taken when a patient is on vasopressor as well. So how do we treat the Kennedy Terminal Ulcer? It is important for a clinician to inform the family that the goal or the focus of wound care is on patient comfort instead of healing. So this is what you call a palliative wound care. You can include pressure relief, protection of the intact skin. You manage drainage or exudates. If there is an odor, you have to manage the odor. If there's pain, you can use anything that could alleviate the pain and suffering of the patient, and of course infection prevention or infection control measures. And if you're a physical therapist working in an acute hospital or in a skilled nursing facility or even in home health, just keep the patient comfortable in bed. Do not get them out of bed. This is the time when aggressive mobilization is no longer the goal. This is not a medical advice. This is for education and entertainment purposes only. Do not change any of your medical regimen without consulting with your provider. That's all for today. I hope you learned something. Do not forget to like and subscribe.